In this module, we will dive into the women's health topics of trauma-informed care to provide the information and tools in clinical practice. As many of you already know, OB refers to obstetrics and covers all things pregnancy-related, and GYN refers to gynecology and covers all other women's health topics. The most common encounters women have at their OB/GYN office includes pelvic exams, pap smears, breast exams, gynecological complaints, family planning, and menopausal health. Just to address the change in communication since COVID-19, the dynamic between medical providers and patients has changed drastically. Although we've mostly downgraded to just a mask, it is still a barrier to communication in an environment that already generally has a rampant lack of health literacy or ability to communicate effectively across languages. Here are just a few examples of communication issues in COVID-19 that have led to reduced perceived communication frequency and effectiveness among patients and unmet healthcare needs. Now we will take a closer look at intimate partner violence specifically, and from here on out, I will refer to it as IPV. One of the scariest statistics in intimate partner violence is that 1 in 4 women have experienced physical violence, sexual assault, and/or stalking by an intimate partner. 92% of those women who experienced IPV have disclosed this to somebody, and 48% of those women who've disclosed it to a medical provider, majority report negative reactions. Some of the negative reactions often discussed among participants were victim blaming, lack of empathy, patronizing, and paternalistic responses. This influences a patient's perceived safety and belonging within the healthcare system and further increases the health outcomes of IPV, including but not limited to PTSD, anxiety, and depression. IPV is a serious public health problem that affects millions of women. IPV is often interchangeable with the term domestic violence. It includes an umbrella of physical violence, sexual assault, psychological aggression, and stalking. It is most commonly perpetrated by former partners, current partners, and individuals seeking a relationship with the person who is on the receiving end of the IPV. It is most prevalent among the pregnant populations, but can occur across all demographics. Pelvic exams and other gynecologic procedures are a source of re-traumatization for many of these patients who experience past trauma. Many patients avoid or delay seeking gynecological care due to fear and anxiety and are particularly concerned about the need to undress and undergo a pelvic exam. Now that I've provided some background information on IPV, I'm going to go over the screening tools, interview skills, physical exam skills, intervention, and support services for IPV. The HARP, HITS, PVS, and WAST screening tools are just some of the many available to screen patients for IPV. These 4 happen to be specifically recommended by the American Association of Family Practitioners, but you can find other screening tools available online. The USPSTF rates it a grade B recommendation for clinicians to screen for IPV in women of reproductive age. They found no evidence on appropriate screening intervals. However, most OB/GYN clinicians are instructed to screen at every single visit. For now, I'm just going to focus on one of these 4 screening tools to give you an idea of what screening a patient for IPV might look like. The HIT screening tool includes 4 questions. How often does your partner physically hurt you? How often does your partner insult or talk down to you? How often does your partner threaten you with physical harm? And how often does your partner scream or curse at you? This can be patient self-reported or staff administered. It assesses the frequency of IPV on a 5-point scale, and each question can be answered on a scale of 1, never, to 5, frequently. A positive screen is a total score greater than or equal to 10. Next, we will move on to interviewing skills when talking to patients about IPV. The first thing I want to mention to you all as future providers are the 4 C's: calm, contain, care, and cope. I like to mention this to providers because it is important to be aware of how you are reacting to the information presented to you, as well as how it is impacting you personally. Try to breathe and stay calm as you are listening to and caring for the patient. Try to contain the amount of information you ask the patient to allow them to maintain emotional and physical safety and respect the time frame of your interaction. Remember to emphasize for the patient and yourself good self-care, compassion, coping skills, resilience, and hope. It is important to take care of both the patient and yourself in these interactions. To actually conduct the interview with the patient, the AAFP created the SOS-DOC framework of interviewing patients about IPV. The first S is for both safety and support. For support, they recommend using normalized language to frame your screening. I ask all women about violence abuse in their relationship because we know relationships can affect our overall health and well-being. That is just one example of how to incorporate the support aspect into this framework. The first S, as I mentioned, also stands for safety. It's important to prioritize the safety and well-being of the patient and address any immediate safety needs by identifying any risk factors that could increase the likelihood that they could experience IPV. Make sure to ask, do you feel safe going home? Are your children safe? And other questions similar to this. Many of the screening tools I mentioned prior will help guide you in asking safety questions of your patients. The O is for options for the patient. You need to discuss how different services are available to the patient and talk about different options to them available after this visit. For example, if they decide to leave, where would they go? Can you keep clothes, money, and copies of keys in a safe place? Do you have a place to go in an emergency? These are some of the various questions you should ask your patient in terms of options that include safety planning and follow-up with the patient. The second S is for strengths. You need to identify and validate the patient's strengths and emotions to build rapport for them and give them the courage they may need to make the next step away from IPV. Some quotes, such as, "You have shown great strength in very tough circumstances. I can see you care deeply about your children. It took courage for you to talk with me today about the violence," are just some examples of ways you can validate the patient's strengths. The DO stands for document. You should try to document any observations you have about the patient. You can include subjective observations, including what they said. Just make sure to use quotation marks. And objective observations that just describe what you observe, any behavior, injuries. Try to also use drawings or photographs when possible. The final letter, C, is for continuity. To emphasize the importance of following through on the smaller details, such as transportation, barriers to access, etc. This may be one of the hardest parts of this framework to follow up on because it does involve making sure you call back your patients, making sure you get in touch with your patients afterwards, and trying to encourage them to schedule follow-up appointments with you so you can continue to check on them and maintain continuity of care. Now we will move on to discussing the physical exam. This is often the most stressful or anxiety-inducing part of the visit for the patient. You should always ask permission, ask about past experiences they may have had with breast or pelvic exams, provide a description of the exam both before and during the exam, offer to shift clothing rather than remove it, not refer to the exam table as a bed, pay attention to their body language and expressions, and agree to stop at any time if they request it. A word on chaperones. Some, if not all of you, will hopefully have experienced the presence of a chaperone in an OB/GYN appointment or visit. Chaperones are there to serve as observers and potential witnesses during sensitive examinations and treatments and are meant to protect patients and healthcare providers. The American College of Obstetrics and Gynecology recommends a chaperone be present for all breast, genital, and rectal examinations, irrespective of the sex or gender of the person performing the examination. This includes in any inpatient, outpatient, labor and delivery, and diagnostic study settings. It is important for you to elicit and address any concerns about the chaperone with your patient prior to bringing the chaperone in. If the patient, after counseling, still refuses the chaperone, you must respect the patient's preferences and document it in the medical record. Give patients an opportunity to talk to the provider alone so the presence of the chaperone does not inhibit communication. Preferably, this will occur either before the physical examination or after the physical examination when the patient is dressed and fully clothed. For the breast exam specifically, keep your other arm that is not involved in the exam by your side and refrain from lifting this hand unexpectedly. Never leave both breasts exposed. Once finishing one side, make sure to cover it with the gown or sheet before moving on to the other side. For pelvic exams, ensure modesty and comfort for the patient by using a sheet to cover both the before and immediately after the pelvic exam. Do not say the word examine or inspect. Instead, say, I'm now going to look at. Also, it is very important to be transparent and set the scene for your patient. Explain that they may feel a great deal of pressure during the examination, but it should not be painful, and to please notify you if it becomes painful. So we've talked about how to identify intimate partner violence and how to lead an interview or exam, but we haven't yet talked about what to do if you've identified someone as experiencing IPV. Your top priorities are first, to be familiar with your facility's protocols and follow whatever protocols they have in place. Ensure the immediate safety of the patient and develop a safety plan. It is also critical to be aware of local, state, and national resources you can offer your patients for more information. There are many interventions and programs available that include services such as counseling, home visits, referrals to community services, and support for the patient. These services can be provided by clinicians, nurses, social workers, mentors, or community workers. I've listed just a few of the local resources below. On this slide, I've just listed some national resources, including both hotline numbers that patients can call and websites they can go for further information. These final few slides will cover trauma in the perinatal period specifically. Birth trauma and previous perinatal loss are two types of trauma individuals who become pregnant can experience in the perinatal period. Sometimes during childbirth, things do not go to plan and there may be unexpected interventions or outcomes. This can be frightening or traumatic for both the mother and their partner. Lack of support or communication from staff or loved ones throughout the experience can also be traumatic for mothers. For example, what is experienced as traumatic is personal, and staff should not make assumptions based on their perception of the health outcomes or care delivered to the patient. Staff recognition of maternal behavior and symptoms that indicate a patient is revisiting past trauma or experiencing the physiological effects of trauma is crucial to improve maternal and baby outcomes, decrease risk of miscarriages, and reduce preterm births. Some of the responses to psychological trauma that you may see in patients are physical, including disturbances in sleep, eating, or hypervigilance, emotional, which can include panic attacks, irritability, or depression, and cognitive, which can include difficulty in making decisions or challenges concentrating. These are just some examples to keep in mind. Keeping the aforementioned broader principles of trauma-informed care in mind, we describe 4 principles of trauma-informed care relevant to the perinatal period: compassion and recognition, communication and collaboration, consistency and continuity, and recognizing diversity and facilitating recovery. Compassion and recognition includes working with your organization to ensure adequate time and privacy to have conversations with your patients about past traumatic experiences. At each stage of pregnancy, make sure to assess for changes in mood and behavior and intervene in a non-judgmental and compassionate way. Demonstrate attentive listening and respond respectfully and genuinely to your patients. Communication and collaboration includes enabling women to feel empowered to be the decision makers for their care throughout pregnancy. During appointments themselves, this can include the physical environment and remaining responsive to any changes to support the mother. It is also important to provide clear explanations and multiple opportunities for the patient to ask questions. You should acknowledge any concerns the mother has and help them understand the options that they have available to them, especially if birth preferences are no longer an option that they are able to continue forward with. As a side note, it is a good idea to encourage the mom to create a printout of their birth and postnatal plans and attach it to their maternity notes so that all staff can access it during their labor and delivery. Consistency and continuity includes attempting to remain the patient's point of care / consistent provider throughout their pregnancy journey, acknowledging how prior and pregnancy related trauma may impact their experiences, and allowing the mother to have time to talk about challenges that they are facing. Many hospitals have actually transitioned to a laborist model of healthcare, meaning the provider on call is the one who will be delivering the baby. This is a newer phenomenon that grew out of the 1990s hospitalist movement era in medicine, intended to improve care through standardization of experience. Many hospitals have transitioned to this model. However, sometimes this can create issues in consistency and continuity of care. OBGYN hospitalists or laborists, the primary role for them is to care for the hospitalized obstetric patients and to help manage any obstetric emergencies that occur in the hospital. In order to maintain consistency and continuity in this role, it is important to have effective patient handoffs, updates on progress, and clear follow-up instructions between healthcare providers in order to protect the patient and maintain patient safety. Finally, the last tenet is recognizing diversity and facilitating recovery. For this, it is important to consider language and literacy barriers, individual differences in ability or willingness to engage in different parts of the healthcare system, usually due to past experiences, and recognizing and understanding the diversity of each patient and of family forms themselves. This is important in order to provide well-rounded care for each and every patient and make sure the care is individualized to their needs. Many poor health outcomes can result from experiencing intimate partner violence for both the patient and their child. Here are some of the ones the CDC listed, and there are many more than this that are also not included. These are just some of the most common you will see. Also, keep in mind, these consequences are often seen at higher rates in marginalized groups and societies. Just to summarize everything we have talked about, IPV is an unfortunate yet common occurrence that approximately 1 in 4 of your patients may have experienced. The use of screening tools to assess for signs and symptoms of IPV is a necessary and crucial part of trauma-informed care that allows practitioners to intervene and prevent further trauma. Offering support and safety, providing resources, and encouraging follow-up appointments in patients with a positive IPV screen is important for care of your patients. Clear communication and use of physical exam tips may help to ensure patient comfort and safety and reduce the chance of re-traumatization. Pregnancy-related and birth trauma among women lead to adverse health outcomes from both the mother and the child. And the use of the prenatal principles of trauma-informed care in the prenatal period to help recognize, discuss, communicate, and foster recovery among your patients will help to improve pregnancy, birth, and OBGYN experiences for all of your patients. Below, I have listed some additional resources to provide patients regarding intimate partner violence. These are just a few available. I know I listed some earlier in the module as well, but I encourage you to research local resources on your own so that you too have resources to offer any patient that may have a positive screen. Finally, in summary, appreciating an individual's prior ongoing trauma is vital to understanding and addressing the significant health impacts it can have. For women's health settings, they offer unique opportunities to develop relationships, coordinate care, and participate in health promotion and education with your patients. They also offer a vital opportunity to intervene in patients who may be experiencing intimate partner violence. Just remember, you can help mitigate the health consequences of trauma, strengthen resilience of your patients, and break the cycle of adversity with trauma-informed care. Thank you so much for listening today, and I hope you have a wonderful day.